Hi everyone, and welcome to today's webinar, Respiratory Protection Program. My name is Ashley McDermott, and I am the Director of Education of OSAP, and I will be your moderator. This webinar is supported by a contract funded by the CDC Division of Oral Health. The contents of the webinar are solely the responsibility of the speakers and do not necessarily represent the official views of the CDC or the U.S. Department of Health and Human Services. Before we get started, I'd like to go over a few housekeeping items. You'll be in listen-only mode throughout the webinar. You can test your audio by clicking Audio Settings in the bottom left-hand corner. If you need closed captions, click on the link provided in the chat. We'll also provide a link to the PDF of the PowerPoint slides. You can submit questions by typing them into the Q&A feature. You can check Send Anonymously if you do not want your name attached to your question. Our speakers will address content-related questions at the end of the webinar. The chat feature has been disabled for participants, but we will be sharing resource links in the chat throughout the webinar, so be sure to watch out for those. This webinar is being recorded, and the recording will live on the OSAP website. The webinar is also being streamed live to OSAP's YouTube channel and is available to anyone. Now for a little bit about OSAP. OSAP is a nonprofit membership organization, and our mission is to be the leading provider of infection prevention control, education, training, and credentialing that supports safe dental visits. Our vision is that every dental visit is a safe visit. OSAP is a one-stop shop for infection control and safety information, education, and training. We have also worked with the Dale Foundation to develop the OSAP Dale Foundation Dental Infection Prevention and Control Certificate Program. The certificate program is available online and can be completed on your own schedule. For the latest information, you can visit dentalinfectioncontrol.org. OSAP is an ADA CERP recognized provider and designates this activity for 1 CE credit. Instructions to claim will be provided at the end of the webinar. I would now like to introduce our two esteemed speakers. Eve Cooney is the Executive Associate Dean at Pacific Dugoni School of Dentistry in San Francisco, California. She has published numerous articles and textbook chapters on safety and infection control and presented hundreds of continuing education programs domestically and internationally. She has worked with universities, nonprofit organizations, and government agencies worldwide to educate dental professionals in infection control and safety and assist in the development of sustainable oral health improvement projects. She is also the chair-elect of the OSAP Board of Directors. Kathy Eklund is the Director of Occupational Health and Safety and the Forsyth Research Subject and Patient Safety Advocate at the Forsyth Institute. She is adjunct faculty at Regis College Dental Hygiene Program, where she teaches a senior level course, Evidence-Based Decision Making. She was the 2017 to 2019 chair of the OSAP Board of Directors and a consultant for the ADA Council on Dental Practice. She serves as faculty for the New England AIDS Education and Training Centers and HIVdent.org. Over the past 35 years, Kathy has published papers and contributed to several texts on infection control and safety. She is an author of the 2003 CDC Guidelines for Infection Control in Dental Healthcare Settings and has lectured nationally and internationally on these topics. Everyone, please join me in welcoming Eve and Kathy.
Thank you, Ashley. I'm going to share my screen right now. And I hope everyone is seeing the screen. I'm not going to read the learning objectives. They were published with the announcement of the course and the course description. I want to also say that the information that we're presenting today is current as of today, which is November 6th. So just back to the basics a little bit. I just want to highlight where we've spent many of our years in dental infection prevention and control in standard precautions, including everything that's based in hand hygiene, universal protective equipment, understanding respiratory hygiene and cough etiquette, sharp safety, safe injection practice, sterilization and disinfection, and understanding the environmental infection control, cleaning, disinfecting, and use of barriers. And this forms the basis of what is, in fact, transmission-based precautions. And we haven't spent a lot of time historically in dentistry talking about and really thoroughly explaining transmission-based precautions in dental healthcare settings. So these transmission-based precautions are in addition to the standard precautions, and they're really designed to interrupt the spread of certain pathogens through contact, droplet, and airborne transmission. So transmission-based precautions are for patients who are known or suspected to be infected or colonized with these infectious agents that really require the more additional infection prevention and control precautions, including certain epidemiologically important pathogens for which standard precautions alone may not be adequate. The three principal routes of transmission in healthcare settings requiring precautions beyond standard precautions, as I said, are contact, droplet, and airborne, and we'll briefly go through and describe these. Now, in terms of droplet transmission, these are respiratory droplets carrying infectious pathogens that transmit infection when they travel directly from the respiratory tract to from the infectious individual to susceptible mucosal surfaces of a recipient that can be in the mouth or the nose. When the infected person coughs or sneezes or speaks, that's one mechanism. During procedures that generate respiratory aerosols, such as what we would have with aerosol generating procedures in dentistry, and pathogens transmitted by the droplet route are not usually transmitted through the air over long distances, however. Coronavirus is thought to be primarily transmitted via these droplets, but may also be transmitted by an airborne route. Now, with SARS coronavirus 2 or SARS-CoV-2, CDC is currently recommending droplet precautions and additional airborne precautions if performing what are called aerosol generating procedures. SARS 2003, which was the first SARS, airborne transmission over limited distances, such as within a room, had been suggested, but not necessarily proven. So I think in terms of looking at this is true of other droplet transmitted infectious agents, such as influenza virus, noroviruses, and a few others. Now, with droplets and droplet nuclei, I think sometimes this can be a little confusing. Droplets generally are considered to be greater than or equal to 5 micrometers or 5 microns in size. Droplet nuclei, however, are particles arising from what is sort of the desiccation. You want to think of it as sort of shrinking of suspended droplets as they dry out a bit, and are defined as less than 5 micrometers or 5 microns in size. These are the ones that have been associated with airborne transmission. The organisms transmitted by droplet route do not remain usually infective over long distances. Now, with airborne transmission, this is the dissemination of either airborne droplet nuclei or these small droplet nuclei, small particles in what are called of the respirable size range. And that is sort of equal to less than 5 micrometers or microns in size. These are the ones containing infectious agents that do remain infective over time and distances. Things including Aspergillus, Mycobacterium tuberculosis. And some of the examples of agents transmitted by the airborne route do include Mycobacterium tuberculosis, rubeola or measles, and varicella zoster virus, chickenpox. Another way to really break this down further, and this came from a paper published in 2004 after SARS 2003. And the authors actually looked at this from the standpoint of 3 sort of categories or classifications. One is obligate, and that's something under natural conditions, where the disease really occurs following transmission of the agent, usually only through inhalation of these small particle aerosols. And again, tuberculosis is a very good example of this. Preferential is natural infection that results from transmission through multiple routes, but the small particle aerosols tend to be the predominant route, and that's where measles and varicella provide very good examples of this. Now, opportunistic are the agents that naturally cause disease through other routes, but under special circumstances may be transmitted via these fine particle aerosols. And this is where we have smallpox, SARS, influenza, and noroviruses. And this is a very good paper. I encourage all of you to access it and read it. Now, with airborne precautions, preferred placement in an airborne illness infection isolation room. Now, that's not really feasible in a lot of dental settings. Monitored negative pressure relative to the surrounding area. Ideally, 12 air exchanges per hour for new construction and renovation, and 6 air exchanges per hour for sort of existing facilities. The air needs to be exhausted directly to the outside or recirculated through HEPA filtration before it returns. And in the absence of an AIIR, supplemental and advanced ventilation may be indicated, though not typically a part of airborne precautions. And I think this is something that is very difficult for most dental settings to accomplish a true AIIR unless you happen to be in a facility that has built that or have access to a hospital that may have these types of facilities available. Now I'm going to turn it over to Eve, and she is going to be covering the sort of nuts and bolts of the Respiratory Protection Program. So take it over, Eve.
Thanks, Kathy, and I want to join Kathy in welcoming everyone and thanking you for joining us for the webinar today. As she mentioned, I'll spend the remainder of our time together talking about the Respiratory Protection Program and then also delving a little bit into types of Respiratory Protection Program. Respiratory Protection Program, as it says here, is a written program, or some people would call it a policy, that's required by OSHA under their Respiratory Protection Standard. There's a lot of things that are included in this program, but they have to be procedures that are specific to your work site that are intended to prevent you from inhaling harmful contaminants in the workplace. So these do have to be something that you, just like the exposure control plan for bloodborne pathogens needs to be specific to how things are done in your facility, the Respiratory Protection Program does need to be tailored to the individual work site. And OSHA has said that the primary objective of the Respiratory Protection Program is to prevent exposure to air contamination or air contaminated with harmful dust, fogs, fumes, mists, gases, smokes, vapors, or sprays to prevent occupational illness. So this applies to many, many, many workplaces, anywhere where hazardous materials are being used that may emit any type of gas or vapor, or for instance, where they're working in areas where small particles are being generated. Next slide, please. The OSHA has some very specific requirements for your respiratory protection program. If you're going to use any type of a respirator, including N95 respirators, you must have a written respiratory protection program. And that's done after you've already instituted any engineering and work practice controls. So things like high velocity evacuation for reducing the amount of aerosols that are generated or that are escape the patient's mouth during aerosol generating procedures, or limiting the number of people that are in a location where they may be exposed. And that's true for any type of PPE, not just respirators. But of course, in dentistry, we have a unique situation where you can't control the exposure to the patient's body fluids through engineering and work practices alone. We do rely heavily on personal protective equipment to meet those safety standards. So because of that, and because of the current SARS-CoV-2 virus, we need to have in place a written respiratory protection program. And a big part of that is assigning a respiratory protection program administrator, somebody with the knowledge and expertise to be able to oversee the program, ensure that it's implemented appropriately, people receive the correct type of training, fit testing, that, you know, if there's any problems, that they have somebody to go to. So I'm going to share with you towards the end of this presentation some good resources resources for how you can access some free training, both for the Respiratory Protection Program administrator, but also for things like the required training for fit testing and use of respirators. The end of the presentation. And so before any employee uses a respirator, and remember this does include N95s, KN95s, and other similar filtering face piece respirators that have approval or emergency use authorization from the FDA. You have to have a qualified healthcare provider review a medical questionnaire, and the questions on that on that form are specified by OSHA and have to be specific. And then the health professional will look at that and determine, based on the answers to that question, whether or not an in-person physical exam is needed. If not, you've passed the first step. The next step is to receive fit testing, which also has very specific standards related to fit testing, and then receive training in the proper use, user seal check, disposal, and so forth related to the use of respirators, including, for the time, information on the OSHA website. And be aware that some state OSHA programs have their own respiratory protection program requirements that may differ slightly from the federal, so you always want to check your state OSHA website too if you're in one of the states with state-run programs. Next slide, please. Piece respirators such as an N95, but any personal protective device that's worn on the face and that it covers at least the nose and the mouth and is used to reduce the wearer's risk of inhaling hazardous particles, which includes infectious agents, which is what we're concerned about. In the United States, respirators are certified by NIOSH, the National Institute of Occupational Safety and Health, including those that are intended for use in healthcare. However, only the ones that are used in healthcare also require authorization by the Food and Drug Administration, the FDA. Next slide, please. So there's a few different types of N95 respirators, and the ones that are designated as surgical N95s will act as both a personal protective equipment and source control. And again, these are also cleared by the FDA, whereas ones that have a more industrial use may not be. We're going to talk about the emergency use authorization in just a minute, but in the interim, during shortages of the surgical N95s, it may be acceptable to use ones that are used for other industries. What is important to understand, though, is that when you have a mask or a respirator with an exhalation valve, it typically cannot be used as source control unless that valve is somehow blocked. Because the way those valves works is they have a membrane inside that when the person who's wearing it breathes in, it will filter the incoming air. But as they breathe out, that membrane pushes out, and it allows their breath to pass through this this vent or this valve, and therefore, you know, the person who's wearing it is completely protected. But if they happen to be pre-symptomatic or asymptomatically infected with COVID-19, they could potentially expose others. Next. And I do think it helps to understand how a product works, and it can help increase the confidence of the people who are wearing it and make them feel comfortable that it is providing them adequate protection. With N95s, I think a lot of us typically think of this as some kind of a sieve or just a simple filter that as air is pulled through, particles are held back. But that's not necessarily the case. The respirator consists of a shell with a pliable metal nose piece to help form it to your face in a way that covers your nose and mouth, and then it has two straps to keep it in place. Typically, on an N95, the straps will go over the crown of the head and behind the neck. In some of the other KN95s and devices that have been authorized under the emergency use authorization, they may have ear loops. The shell's covered by a polyester lining. It protects the flat, non-woven, fibrous filtering material, which is most often composed of polypropylene. The fiber diameter, permeability, and filter thickness determine how well the N95 will perform in protecting the wearer. And there's 4 forces at play which help that filter collect and also strongly hold particles. The first one, called inertial impaction, occurs when large particles are slowed by the inability to pass through the filter and they become trapped in the filter material. The next one is interception, where the fibers are capturing large particles and they prevent them from passing through. There's also diffusion that comes into play, where smaller particles are bombarded by air particles and pushed into the fibrous web. And then finally, electrostatic attraction, in which fibers attract and contain oppositely charged particles. And so all of these mechanisms together create a stronghold in which it's difficult for particles to be removed and to reach the airway of the person who's wearing it. But the filter is only as good as the fit. So it's critically important that the fit be tested, that it be checked each time the person wears it in order for this device to perform as intended. Next. So I mentioned FDA Emergency Use Authorization, also called EUA. And this is something that's being done during the public health emergency related to COVID-19, which was declared by the Department of Health and Human Services. It temporarily allows the use of some respirators that have not been tested and authorized by NIOSH, which would typically, be required. The FDA would not normally authorize the use of an N95 until it's been tested and authorized by NIOSH. But of course, we've had shortages. We're all very well aware of them. And this has prompted the FDA to try to assist healthcare providers with the use of other devices that may be available. Some of these are respirators that are not intended for healthcare, but they are manufactured by the US and they may be tested by NIOSH, but not typically used in healthcare settings. And so some of those on the list will be that type, and others may be ones that are manufactured in other countries, like the KN95s that we hear a lot about from China, and those will also appear on the list. Be aware, however, that this list is updated frequently, and so it needs to be checked. I would say, for an example, early on in the pandemic, when we were just providing emergency care at the dental school where I work, we were able to obtain some KN95s that were on this list. And then when we went to reorder them and we rechecked the list, they had been removed from the list. So we needed to source some different ones. So you do have to kind of keep up because things change. Next, please. Respirator fit testing has been a difficult challenge for many people during this pandemic. For one thing, in dentistry, for most of us, this has been a new area that we didn't ever have to do before. But again, it is required by the OSHA regulations. They require initial fit test and also annually thereafter. During the COVID-19 pandemic, they've temporarily suspended enforcement of the annual testing, but you still need to do the initial. And the other thing to be aware of is if you switch brands or types of respirators, then another initial fit test needs to be done. So say you switch from, brand X, and now you're using brand Y, and they're not compatible or similar, you'd have to do a new fit test. The fit test works usually by taking, this is an example of a fit test that you can purchase through a lab safety company. You would have the person put their respirator on, put that little yellow hood that you see over their head resting on their shoulders, and then usually either a bitter or a sweet agent is used in these little nebulizers to put some puffs of that into that space underneath the hood. And if the person wearing the respirator can detect the bitter or the sweet, then you know that it's not fit properly and it needs to be adjusted and continue to fit test. And we have had situations where certain respirators just don't fit certain people's faces, and so it may be necessary to have more than one brand available. These fit tests can be done by, say, an occupational health professional. Certainly that's a very common kind of person to have do your testing, because they do it all the time for all different types of industries, but it can be done really by any proper trained personnel. And because these fit test kits are available commercially, you can buy them, by going online and just, doing a Google search for fit test kits. You could conceivably train somebody in the dental facility that you're at to do this training. And some of the fit test kits come with the training materials, and others you have to buy it separately. But the person would need to be trained, would need to understand the proper way to do all of the fit testing and to be able to determine whether or not they were successful. There's another type, this is called a qualitative fit test. There's also something called a quantitative fit test, but that requires some instrumentation that helps measure the air, how the air is, how the mask is being sealed while the person's wearing it. At any rate, it's important to always really carefully follow the instructions. Next. These are just some infographics that I borrowed from the CDC website. I thought they were very good. And I think you could find them online by going to the CDC in the respirator section. They have a lot of actual infographics and posters and things for PPE that we've found very helpful. We're currently back treating about 400 to 500 patients a day at our facility. So we, are using as many resources as possible to make sure people are using the right PPE and they're using it correctly. So this kind of goes through the step process of the proper way to put on an N95 respirator. I think that, first of all, you use a clean hand, hold it against your face, and it should be a new respirator. If you're reusing a respirator, you're in crisis capacity, and there are some other things that you need to be doing, which I'll talk about just a little bit towards the end. The strap goes over the top of the head, and then the bottom strap goes around the neck. And one important thing I think that people sometimes overlook is if it has a metal nose piece or a nose clip, you need to press that down gently with the fingers of both hands to make it form around the curve of your nose. If you pinch it together, you can create a gapping that will not allow you to get a proper fit. So pressing with both hands, then doing what's called a user seal check, where you put both hands over the face of the respirator and sharply breathe in. You should feel a slight collapse, and then breathe out, feeling for any air escaping around the edges of that respirator. And then be sure the other PPE that you're using doesn't interfere with the fit or performance of your respirator. Things like the strap from a face shield, or, I've seen some people put a surgical mask either under or over their respirator. You need to be cautious about that because it could interfere with the seal and the fit of the respirator. And so, think carefully before you put anything on top of your respirator because it could interfere with the function. Next, please. If you are under crisis capacity use of PPE, and you're having to reuse a respirator, you of course would want to always handle it with gloved hands, not with bare hands, as we showed in the previous slide. And you wouldn't use one that appears damaged or deformed or in any way where you can't get an effective seal to your face. It fails the user seal check. If it becomes wet or visibly dirty, or if it becomes difficult to breathe through, I think I'm going to talk about this in a moment, but it's also recommended that you not try to reprocess and reuse an N95 or other type of filtering face piece respirator if you've been doing aerosol generating procedures. So that kind of eliminates it for most of us in dentistry. Watch out for the facial hair, jewelry, glasses, or any other type of clothing that comes into contact with your respirator. And also don't crisscross the straps behind your head. And don't wear it if it doesn't have a proper seal. If you're finding that air leaks out, and again, that user seal check should be done every single time you put a respirator on. And it only takes a few moments. But if air is leaking around, you need to adjust the straps, maybe adjust the nose piece, reposition it on your face, try the seal check again. And if you're still having trouble, reach out to your Respiratory Protection Program administrator and have them assist you. And then don't touch the front of the respirator during or after use because it could be contaminated. Next slide, please. And then finally, just proper disposal of the respirator. You want to avoid touching the front of the respirator with your hand. So you remove it by first pulling the neck strap up and over your head and letting it dangle in front, and then just grasping it by the top strap over the head and pulling it away from your face, and then you can just discard it into a waste bin. Of course, you want to clean your hands with either alcohol-based hand sanitizer or soap and water in case your hands have become contaminated while you're handling your PPE during removal. Next, please. So this is what I was mentioning before, that under crisis capacity standards of care, where we know that we're not meeting our normal standards of care, we're doing it because we have no other alternative, there are no N95 respirators available, you've already stopped treating patients for anything other than emergency or urgent care, you're limiting the number of people in the facility, and then you may be needing to, at that point, that was when you could potentially decontaminate and reuse a filtering face piece respirator, which FFRs is the broad category for any type of that type of a filtering face piece. N95 falls within that category. So the only types of decontamination that have been found to potentially be effective are ultraviolet germicidal irradiation, which is UVGI, vaporous hydrogen peroxide, and certain types of moist heat, which I'm not talking about a steam autoclave in this case. The filtering face piece respirator should not be worn by healthcare providers when they're performing or being present for an aerosol generating procedure. So that's why I'm saying not much usefulness in dentistry, since almost many of our procedures are AGPs. And also, if you're using any kind of a respirator that's on that list from the FDA, these emergency use authorization, those also should not attempt to be decontaminated. Next slide, please. There are some additional types of respirators, and I think these have been getting a little bit more attention, especially recently, because there are still intermittent shortages of N95s. It's kind of interesting the way that these shortages kind of come and go, that even with the fit test kits, in May and June, there was no way we could get those at all, and then suddenly in August we could, but then you might see in October, again, it's difficult to get. So these shortages seem to come through in waves. But other types of respirators that you may have seen or heard about, the one on the top of these, the two pictures on the right, the one on the top is called an elastomeric respirator. It has a frame that's reusable and can be disinfected or decontaminated, and then you attach canisters to it, and usually the canisters may be single use, depending on what you're using them for and who the manufacturer is, but the canisters would be for specific things. So you might have the elastomeric respirator frame, but you want to be sure that you have the right canister. You wouldn't use one that's for gases and vapors. You would use one that's intended for infection control purposes for very small particles. Those also, you need to be cautious because they often contain an exhalation valve. I know that one of the companies, I believe it's 3M, is currently offering a device that can block that valve that you can add on to the frame. Other people have used things like surgical tape to put over the front of the valve to block it off, because again, it doesn't provide any source control. And right now, because of the pandemic, we not only want to protect the respiratory tract of the person wearing the respirator, we also want to protect our coworkers and patients who may be exposed to our exhaled breath if there are these valves present in the respirators. I mentioned before that there's all different kinds of filtering face piece respirators, which are called FFRs. There's the KN95, and then in Europe they use a different designation. They're called FFP1, 2, and 3. An FFP2 would be equivalent to an N95 respirator. It filters about 94% of small particles, where an N95 filters 95. That's why it's called an N95. There's others too. There's N99s. There's different types of N respirators, but they all have to have either be NIOSH approved and already approved by FDA, or they have to have the FDA emergency use authorization and appear on that list. And we did provide you with that website so you could check it out. And again, just the source control is an issue that we need to be aware of and think about. The other type of respirator that you see here on the bottom right is called a powered air purifying respirator, often referred to as a PAPR. That needs to be a tight face-fitting type of respirator if it's to be used for our purposes, because again of source control. If it has a looser, what they call the drape that goes in the front, then some of your exhaled breath could escape. Next slide, please. So last month, OSHA came out with some temporary enforcement guidance on PAPRs for healthcare, and that it says that the OSHA inspectors can exercise discretion in enforcement of fit testing if fit testing materials are not available. So that doesn't give you a carte blanche to just say, oh, well, OSHA said we don't have to fit test. It's if you've tried to obtain the fit test materials, or you've reached out to a local occupational injury clinic and they've said we don't have the fit materials, we can't do your fit test, then the OSHA inspectors would exercise some discretion in enforcement, but not if you weren't making the effort. And it only applies to fit testing of NIOSH approved tight-fitting PAPRs that are used at a contingency capacity strategy. So under standard capacity, you would use an N95 respirator if you felt there was a risk of encountering somebody with SARS-CoV-2. Under contingency capacity, it means that you can't necessarily source N95s temporarily, so you might use a PAPR instead. And that's when you're using, when performing job tasks with a high or very high occupational exposure risk to SARS-CoV-2. And if you can recall, back in, I think it was probably in March, perhaps early April, OSHA came out with a document where they identified low, moderate, high, and very high risk procedures in healthcare. In dentistry, very high risk was performing aerosol generating procedures on patients who were known to be infected with SARS-CoV-2. High risk would be all other aerosol generating procedures. So those would be the two where it would be okay to use a PAPR during this contingency capacity strategy. Next slide, please. So this OSHA document does not apply to PAPRs that have not been approved by NIOSH, so you shouldn't be using those. PAPRs used by any workers with low or medium exposure risk to SARS-CoV-2. PAPRs used by any workers for protection against airborne hazards other than SARS-CoV-2. So, they'll still enforce it, say, for people that have to wear it due to chemical hazards or other, industrial type of uses. And also loose fitting hooded PAPRs that don't require fit testing. But remember, if they're loose fitting, they could also not perform or function well as source control. Next slide, please. So this is where I promised you we could have some resources for the Respiratory Protection Program. I found this really useful early on because, we did not have a respiratory protection program that addressed healthcare workers at our school. We only had respiratory protection program for, some of the facilities personnel who did certain things like painting. So we went to OSHA and found this publication, the Hospital Respiratory Protection Program Toolkit. That toolkit has a template for your written respiratory protection program, and you can, because it's for hospitals, there are certain things in there that really just don't apply to ambulatory care or outpatient settings. So, you can just remove those sections, but it'll take you step by step through what it is you need to do to develop that program. There's also checklists and things like that. And again, check with if you're in a state with a state-run OSHA program, they may have additional resources, or their requirements may be slightly different. I know, for instance, in California, the California Department of Public Health had a whole bunch of really great resources for respiratory protection program. Also, because they're going to be with us for a while, quite obviously, it's important for us to really understand information about respirators. This is a new area to us. We have a steep learning curve that we need to follow, and one of the ways you can do that is by going to the National Institute of Occupational Safety and Health, which is NIOSH, and you can see the URL right there, and they have a whole section on respirators, and reading some of those resources will help you understand more about the details about how respirators function, how to properly use them. They have some videos and some training materials and things like that on their website too, which is very helpful. And the American Association of Occupational Health Nurses, AAOHN, on their website have a lot of online training modules, and they have two great sets of modules. One is the general training for the respiratory protection, and it's intended for healthcare workers. It was developed under a grant by NIOSH, and it covers all of the required elements for training. I think I found it extremely useful. I use it to help train some of our personnel, some of our faculty and our students. And one module is the general training, and I think it's a couple of parts, 2 parts, and then a final part, which is a self-test, and then it gives you a certificate that you've completed the training. But the other module that you may find really helpful if you have not assigned a Respiratory Protection Program administrator yet, or you are the administrator but you don't feel like you really have the expertise, is that they have training modules for the Respiratory Protection Program administrator as well. It's a little bit longer. I think the general training probably takes about 30 to 45 minutes, and the administrator training is a little bit longer than that, maybe an hour to an hour and a half. Very worthwhile though, you'll get a lot out of it, and it's free since it was developed with federal funding. And then the next slide is some more information about what OSAP can provide. OSAP partnered with the DentaQuest partnership to develop some resources during the pandemic. The one that's being shown here is a best practices document, kind of in the, it's almost like a checklist. You go through and it walks through the different best practices for infection prevention during the COVID-19 pandemic in dentistry, and it can be found on the OSAP website. It's a free resource. Next slide.
I just wanted to add, Eve, it's actually a living document as well because it reflects all the current guidance from CDC as well as OSHA and professional organizations, including the American Dental Association and the American Dental Hygiene Association. So anytime guidances are updated, the checklist is updated, so you can visit it frequently and download it.
Thanks, Kathy. Yeah, that's a good point. You know, it's not a one and done. As we've learned throughout this pandemic, that things can change, and that's not necessarily a bad thing. Some people find it frustrating, but I know the way I like to explain it to my students and my colleagues at work is that, you know, we all know that science and medical science in particular is a journey of discovery, and you know, as the science advances and as more information is not only discovered but reinforced through you know, replication of good studies that show that yes, you know, this is actually confirmed to be you know, a new fact or piece of information about this pandemic, we'll see recommendations change. We'll see, you know, county health orders change, and that's good, but it does require a lot of vigilance to keep on top of that. The other thing that OSAP and DentaQuest did together was develop this patient resource. It's a resource that can be given to patients to help them understand the type of steps that we're taking in dentistry to make them feel safe at the dental office. And so that's also available on the OSAP website.
Yeah.
Next slide. And then finally, just want to mention every year we do a boot camp with OSAP. It's a several day long kind of nuts and bolts infection prevention and control course. Lots of great faculty, lots of great information. Of course, in 2021, as with every conference that I've heard or been invited to in the past 9 months, will be virtual, but it is a great way to get all of your infection control information, especially good training for people who have a lot of responsibility for infection control. So maybe they're their infection control coordinator or the compliance officer, but really for anybody who's in dentistry. Next slide, please. We have We have about 15 minutes left, so I think we can take about most of that time. We have a couple of housekeeping things at the very end, but we can go ahead and I'll invite Kathy to rejoin, and we'll talk about, we'll answer some of these questions. Kathy, why don't I just take the first one and you take the next one and we'll go on down the line. Does that sound good?
Sure, that sounds fine. I'm gonna, I guess, should I stop sharing my screen? I'm not sure what will be up if I stop here.
No, go ahead and leave your screen up because we have a couple more slides with some housekeeping that we're going to need to advance to when we're done. So I'm going to start with at the top. I'm going to go from the top to the bottom. What about KN95 respirators? Rumor says KN95 masks don't need to be fit tested, and the truth is that yes, they do need to be fit tested according to OSHA. I know that I will say that the ones with ear loops, in our experience, have been much harder more difficult to fit test. That the majority of our personnel who tried to be fit tested using those failed, but that may vary from brand to brand, but any respirator does need a fit test.
Okay. I guess the next one was, is it safe to use an N95 with a valve as long as you wear a level 1 or level 2 mask? It's hard to follow the Q&A because it keeps jumping around. As Eve said, the issue becomes you want to avoid using one that has a valve if at all possible because of the source control issue. If you would be covering it with a face mask, you also have to be very careful that you're not going to alter the fit and the seal of the KN95 respirator. So first choice would be if you can avoid purchasing ones with valves. Second would be covering it, but very carefully to ensure that you can still keep a correct seal.
Or Kathy, I would even say that instead of sacrificing, a surgical mask, which, with our PPE resources,
Right.
you might want to consider covering the valve with something like
Surgical
medical tape. Yeah.
Yep, surgical tape.
Since OSHA covers employees, how do you address students in the written program? I'll answer that since I picked that one since I work in education. And it depends on your personal philosophy. Our philosophy at the dental school where I work has always been that we want to model appropriate behavior to our students and the behavior that they'll need to follow when they are themselves employers. So we provide the same benefits, if you will, to our students as we do our employees. So because we have we fit test 200 or 300 people at a time, and we hire a vendor to come in and do that, and we don't charge our students back for that. But that would be a possibility, that if you have a way to include that into your student fees, say that, okay, now we're going to have an annual fit test fee that goes along with the other fees that we have, incorporated into their kit fee or something like that. But that's just how we do it. Kathy, I'll let you take the next one.
So the clinic has no aerosols. I guess it means that they're not performing any aerosol generating procedures. And in terms of wearing a mask with a face shield, the current CDC guidance is that if you are not performing aerosol generating procedures, that an FDA cleared surgical face mask can in fact be worn. Obviously, wearing a face shield over it helps to protect it from becoming wet, but also these should be changed after each patient.
Okay, I see here one that some people have said that the N95 can be used up to 5 times if they place a surgical mask over it in dentistry. Is that true? That kind of speaks to what I was mentioning before, which I would actually encourage everybody to go to the CDC website and put in the search term for PPE optimization, because there are some very specific guidelines on what to do if you're faced with a situation where there's a shortage. Where there is no shortage and you're able to, you have an adequate, say you have a 2-week supply of N95 respirators, they should be changed after each use or between each patient. And so therefore, you want to avoid, and there's no set number of times you can wear it either. I mean, it could be that the fit doesn't work very well after one time, or that it gets wet because you're doing, an aerosol generating procedure. It also gets wet just from the moisture in your exhaled air. So there's no set number of times an N95 can be reused, but it can be reused if necessary under contingency or crisis capacity.
Yes, and there's an additional webinar that we'll be doing that's going to cover that PPE optimization, covering that more in depth. It says, can you continue to rewear the same mask with a covering of a face shield? If you never touch the mask, just remove the face shield for comfort. One of the things to keep in mind is the CDC guidance currently is that you should change and dispose of all disposable personal protective equipment after each patient. And so the problem with continuing to wear surgical masks is just like with what Eve had said with the N95 respirators. It can become wet just from your own breathing. So follow the current CDC guidance, cdc.gov/oral health, click on reopening, and you can get directly to the guidance.
So I have one here that we've faced too, is that we have providers who can't shave their beards for religious purposes. What can they wear? I understand that the tight-fitting PAPRs also do not form seals with beards. We were told that a PAPR or a capper with a hood was appropriate for source control. And I think to this person's question, this is a very individual thing. It depends on how far their beard extends. It depends on the brand and type of PAPR or capper that you wear. But you're absolutely correct. In the guidance document from OSHA, they do talk about this, and they say that that if you have to wear a loose-fitting PAPR because of the facial hair that is worn for religious observance, then that should be allowed to be done. Do you have anything to add to that, Kathy? Because that's kind of a difficult area.
Yeah, it is, but I think you covered it very well. The next question is, are small dental offices required to have a respiratory protection program, or is it clinics over 50 people? No, it's all facilities, and no matter the size. That's not the issue. And it's so important to have a respiratory protection program, including the training, the fit testing, the medical evaluation, because first you want to make sure someone can safely wear a respirator. And secondly, that it can be fit tested properly. And then thirdly, that they are trained on how to ensure they have an appropriate seal. Because if you don't, and someone doesn't have an appropriate seal, it's not respiratory protection. So it's really important to have that respiratory protection program. Eve, did you have anything to add to that?
No, I don't. I'm just looking at the other. So this is a question that we get whether or not it's a pandemic. How does the office OSHA standards coordinator address a non-compliant doctor who's not following OSHA standards? We occasionally see that question related to bloodborne pathogens too. I think that it puts people in a difficult situation if that person if you're the one who's tasked with being the coordinator for OSHA compliance, if that doctor's the practice owner, you're not going to get too much traction. But say you're working in a DSO or something where the doctor's an employee of that practice rather than the practice owner, I would definitely talk to them individually as you would with anybody else. And then if that gets you nowhere, I think you have to go up the chain of command, maybe as far as the practice owner or the person in charge. If they're the practice owner and they fail to do that, you only have a couple of options. One is find another job. I mean, that's not a great solution. You can report violations to OSHA or licensing board too, but those are all difficult options, but they're ones that you have to think about when you're faced with something that you truly feel is compromising the safety of patients or coworkers. Do you have anything to add to that, Kathy?
No, and I think, you know, you always want to start with communication, and so everybody really understands what the issues are, and not, you know, as always in infection prevention and control, but especially now during this pandemic, you need everybody in the facility to be on the same page relative to safety of patients as well as personnel. I'd like to address a question that came in. If one is just providing dental screenings and fluoride varnish for elementary school age children, would you need to write a respiratory protection program plan, regardless of whether an N95 respirator is worn or not? Number one, if you're not performing aerosol generating procedures, current guidance is you would not need an N95 respirator. So if you're not wearing respirators, you would not be required to have a respiratory protection program. If, however, you are going to have individuals wear respirators, then you definitely would need to have a respiratory protection program. And I think this is something that a lot of programs and school-based sealant programs are facing right now, as some schools are opening up and allowing people to come back in. You want to take one, Eve?
Sure. I'm always attracted to the questions about students. Do transient students observing in the dental practice require a respirator fit test? So that I'm guessing that's maybe either a community clinic or a practice where they offer assisting or hygiene or dental students to come in and observe. And I think, you know, one of the things that is a bit concerning regarding COVID-19 is the increasing evidence that it can be transmitted through the airborne route. And if that's the case, that means over longer distances than you would normally see, say, with the droplet route. And because of that potential, reconsidering who in the practice may need to wear a respirator, if they're really in close proximity, even if they're not performing the procedure, but they're right there in the treatment room with you and everybody else is wearing a respirator because you feel it's necessary, then chances are you would want to afford that same protection to people who are in the area observing. Another thing to consider is during a pandemic, is there really value to having passive observers in an area where there's a risk of airborne disease transmission? I know that for us, all of our community clinic rotations, even our students even provide care, but our community clinic rotations have been temporarily suspended because of the pandemic. So that would be another thing to consider is, does that person really need to be there? And if it's part of their school or course curriculum, you know, maybe that question could be posed to the people who are in charge of making the decision regarding these types of rotations. I see that we're down to just 2 minutes, so I'm going to ask Ashley a question, and that is, if we capture the rest of these questions that we have not been able to answer live, can we answer those and put them on the OSAP website or elsewhere?
Absolutely.
So is there a way to let participants know where they'll be able to find these?
Yes, so actually after the webinar is over, it may take me until next week, but we are going to be putting a recording of this webinar on the OSAP website. So it will live there and we can maybe add the questions to that page if that, so it will have the video, the link to the PDF PowerPoint slides, the transcript, and we can add also these extra questions.
Excellent, thank you.
Yeah.
So I'll turn this back over to Ashley now to talk about the CE verification letter, but I want to thank OSAP and the Centers for Disease Control and Prevention for allowing us to do this presentation today. Thank you very much.
Yeah, I'll join you in that, Kathy. Thank you, and thank you all for being here.
Yes.
Yes. Thank you to our esteemed speakers. We're always so glad to have you help us with these webinars. So for everyone who is interested in receiving CE, you'll need to complete a brief online assessment and evaluation. The link to the CE quiz has been added to the chat, so you can go to that link. If you have any trouble, definitely reach out to OSAP. Our email is up here. We're office@osap.org. And as I mentioned, a recording of the webinar will be added to the website and available to anyone. So if you had any coworkers or friends, definitely send them to the OSAP website. It will continue to be free. So we do encourage everybody to come check it out. And I think with that, have a great rest of your weekend.
Bye, everyone. Stay safe and be well.
Bye.
Bye.